Linda?
Thanks very much. I really appreciate the opportunity to be here today. It's been a great morning and early afternoon, and in fact, I feel like most of what I have to say has already been said, so you'll hear a lot of recurrent themes here. Connie Mitchell is going to talk after me about some of the more pragmatic issues in the Health and All Policies Task Force, and what I wanted to do today was just share some of my own reflections based on my work as the first and convening chair of the California Health and All Policies Task Force, and more recently working with local health agencies and local city governments and county governments around California as they try to implement some form of health and all policies. So our definition in California of health and all policies is a collaborative approach to improving health of all people by incorporating health considerations into decision-making across sectors and policy areas. That really starts with informing decision makers about the health, equity, and sustainability consequences of the policy options that are under consideration, with the hope that policy outcomes will reflect those consequences, knowing full well that there's many things that go into making policy and that even people that are informed may not make the choices that we wish that they would. The conceptual underpinnings of our health and all policies work in California are as follows, and I'm basically going to repeat a lot of what David Williams said this morning, but in short form. First, that the physical, social, economic, and services environments in which people live, work, study, and play are the key determinants of their health choices and their health outcomes, and that stark differences in these environments contribute to persistent social and health inequities in disadvantaged communities that have unhealthy environments, few resources, and few opportunities for health, and thus significantly unhealthy outcomes. Second, and Mr. Collier also showed the BARHI framework, the Bay Area Regional Health Inequities Initiative framework, but this framework basically shows graphically that these environments, the living conditions that are determinant of health outcomes, are largely shaped by institutions, businesses, agencies in sectors outside of health: finance, education, housing, employment, parks, and so on. And third, and this is a very oversimplified slide, that the same forces that shape living conditions shape systems: transportation, energy, agriculture. Those systems are shaping our living conditions, but they're also the same systems that have led to global environmental impacts such as air pollution, the loss of access to fresh water, ecosystems collapse, soil loss, and climate change, which is the single biggest public health threat of this century. In addition to its many direct health impacts, climate change literally threatens the systems on which human life depends. Climate change threatens our air, our water, our food, our shelter, and our security. And if we don't seriously consider climate change amongst other major ecosystem challenges, we will not achieve health and equity, no matter how much we think we're addressing health and all policies. We were fortunate in California because California's health and all policies work actually began as an outgrowth of discussions about the convergence and concordance between obesity prevention strategies and strategies to reduce greenhouse gas emissions, which I'll come back to shortly. So this conceptual framework really informed all of our work in establishing the Health and All Policies Task Force in California, and it led us to identify these key 5 elements in the implementation of health and all policies. And because time is short, I'm not going to go through each of these. I just want to highlight a few thoughts on some of them. First, we use the word health and all policies as a shorthand for health, equity, and sustainability in all policies. When we convened the Health and All Policies Task Force with 19 member agencies, Our first challenge was to develop a shared understanding of health, thus helping us form a shared vision and shared goals and objectives. We did this by asking task force members and people around the state of California and community-based organizations, NGOs, local health departments, and city governments. When you think about health for yourself, your children, and your friends, what do you think the term healthy community means? And through an iterative process, we developed this framework. And I want to mention that Neil Maislish at the California Department of Public Health is currently working to develop a sort of a set of core indicators that matches this framework. It's desperately needed. Lots of people are talking about metrics. I imagine that almost everyone who's talking about them today has their own metrics that cover many of these same topics. We need a healthy communities version of Healthy People 2020 that really lets us have some common standards for talking about the elements of a healthy community. So I have a couple of different quotes up here about sustainability, but I want to say a word about why health and social equity within the U.S., global equity, and perhaps most importantly of all, intergenerational equity cannot be achieved without very serious attention to ecosystems and climate change. The climate gap refers to the disproportionate impact that climate change is and will have on vulnerable and disadvantaged communities here and around the world. The climate penalty refers to the fact that climate change acts as a threat multiplier. It will make it much harder for us to have clean air and reduce air pollution in our very polluted cities, because as temperatures rise, ozone levels will rise. It will make it much harder for us to address food insecurity, because as drought and heat impact crop yields, asthma and cardiovascular, as drought and heat impact crop yields, food prices will rise. And we already saw significant 5 to 7% increases in a number of important food baskets because of the drought of 2011 and 2012. And affordable housing will become more difficult to find as more superstorms, hurricanes, forest fires, and floods create huge waves of displacement and both internal migration and migration from more seriously affected countries. In California, the nexus between health equity and sustainability was explicit in the placement of the Health and All Policies Task Force under the auspices of a cabinet-level body whose job was to coordinate agencies around sustainability and climate change. And we were specifically charged to address co-benefits among health, climate change, equity, and economic well-being in our formation. But health and all policies initiatives in other jurisdictions are going to have to pay more conscientious attention to the nexus between these issues as they do their work. So, maybe? Yeah. So a lot of people have addressed the concept that when we collaborate around these kinds of issues, we have to balance the fact that health is our central goal with the fact that it's not always the central goal of others. And we need to be really respectful that others have very, very important goals and mandates as well. And others have also addressed how hard it is to take the time, the listening, have the humility to build relationships that really allow the kind of trust building that's required to move these issues forward and to find the paths that let people feel like everybody's important, everybody's values and goals are being respected, and you're truly working in partnership and collaboration. Identifying and prioritizing strategies with health and sustainability co-benefits, or win-win strategies, no-regret strategies, there's lots of names for it, is one important way to promote collaboration. And just as an example, CDPH did a study demonstrating the potentially huge health benefits of shifting, feasibly shifting from driving cars to active transportation. we could yield health benefits as big as some of what we've seen with our tobacco control efforts through the increase in physical activity associated with modest shifts in mode of transportation. When we provided this information to our transportation agency and the land use agencies in California that were charged with decreasing vehicle miles traveled for the purpose of reducing greenhouse gas emissions, they found it extremely helpful. But sometimes we don't have co-benefits, and we have to deal with very complex, wicked challenges like in Los Angeles, a lot of affordable housing sites are right next to freeways. A lot of the proposed transit-oriented development sites are right next to freeways. So affordable housing is important from a health perspective. Transit-oriented development is important from a health perspective, from a regional air quality perspective, from a climate change perspective. But we also know that people shouldn't live next to freeways. We know there's reproductive, respiratory, and cardiovascular impacts of living next to a freeway. How do we address the affordable housing advocates that are afraid that smoke-free multi-unit housing policies are going to be used as excuses by tenants to kick them out and gentrify their neighborhoods? It's exciting to me that health and all policies in many forms and under many different guises is spreading internationally and across the United States. But I want to step back from that excitement with a note of caution. Aaron pointed out that the concept of health in all policies and cross-sectoral collaboration in health is not new. Many of our signature public health achievements required significant intersectoral collaboration. We are building on those and on the multiple prior statements and ensuing movements that have rallied public health multiple times to address the social determinants of health. What will it take to keep health in all policies from being essentially another trendy but unsuccessful movement, especially in the face of dramatically rising social and economic inequality and in the face of the urgent challenge of climate change? We need real structural and procedural change that embeds and institutionalizes consideration of health equity and sustainability into the culture, organization, and processes of government. We need support and opportunity for substantive community and stakeholder engagement that empowers participation of the most vulnerable. But more inclusive decision-making and active participation alone won't work unless we directly address very fundamental issues about how our society distributes resources and power. We need to reframe our social discourse about health equity and sustainability. We need to reaffirm that we value as a society health for all, and that protecting our health, our neighbors' health, global health, and the health of the planet are important priorities for our nation and thus for our government. And I agree with Aaron that this can only happen if we're really, if we have strong and visionary leadership, and if we're really willing to engage in the political process and have the political will to challenge the status quo and mobilize robust social movements such as those which our health in all policies forebears were involved in. Thank you.
Thank you, Linda. Joining us by video is Connie Mitchell. And Connie is the Chief of Policy Unit in the Office of Health Equity at the California Department of Public Health. And as you know, Linda previously headed up the Health and All Policies Task Force, and now Connie Mitchell is currently the chair of the Health and All Policies Task Force. So do we have Connie?